All right, let's talk about signs and symptoms. Very quickly, I'm going to give you a sign and symptom, and you're going to give me the rationale. Y'all should be like, by now. Yeah? Yeah. All right. They will have polyuria. Lots of peeing because your body is trying to get rid of the excess sugar, and they're drinking a lot too, so obviously that would make sense. Yes? They have polydipsia. Polydipsia is they're okay. So they're very, very thirsty because they're losing a lot of fluid through the kidneys. Yes? Okay. Why would they have polyphagia? All right. There's no actual glucose in the cells. The cells are starving, so are you. Yes? All right. Why would they have blurred vision? Diabetic retinopathy, increased IOP, and then there's lots of sugar inside the eyeball, which can make things appear cloudy or blurred, right? Paresthesias. Why might a patient with type 2 have paresthesias? Sugar builds up around the nerve cells, eventually causing nerve damage. Yes. Okay. Acanthosis nigricans. Did we talk about this? It's a dark velvety line. You can either see it across the back of the neck or you can see it under the axilla. Have y'all seen it? Do y'all know what it looks like? No, this is actually buildup of sugar underneath the skin. Okay. So if you have acanthosis, okay, it tells us, now you can't diagnose off of that, obviously, because they screen all eighth graders, by the way, and every public school gets screened for acanthosis. If we see, acanthosis, well, I don't know if you go to private school. They probably won't. But acanthosis tells us, pass it down. Acanthosis tells us that there probably is some insulin resistance. We cannot diagnose type 2 diabetes off of somebody's skin, right? But what we would tell the parent is this is an indication. Y'all probably seen this on people all the time. Yeah. Y'all are going to start walking around the grocery store and be like, he got PAD, he got diabetes. Like you can start diagnosing people. But anyhow, so that tells us that they possibly have insulin resistance. And what they will say, they'll describe it as a hyperpigmented velvety line. Okay. And it goes in grades 1, 2, 3, 4, and it matches the centimeters. So 1 centimeter is grade 1, 2 centimeters is grade. Good job, everyone. And so forth. Okay. Why would they have fatigue and weakness? They don't have any energy because there's no glucose in the cell to use for ATP. Irregular menses. Their estrogen is massively off. Hormonal imbalances, right? So they will have irregular menses. Frequent UTIs and yeast infections. Lots of glucose going down to the tay-tay. Weight gain. Why would they have that? Okay, well, they are eating too much, but also remember we're increasing cortisol and aldosterone, which causes fluid retention. Why would they have anergia? Lack of energy because there's no glucose to make the ATP in the cell. Glucosuria. They're peeing out a lot of glucose, which tells me that their blood sugar is already how much? 250. It's at least 250 before you start spilling in the kidneys. Hyperglycemia. Okay, that's a given. Erectile dysfunction. Why might they have that? Well, it does mess with your nervous system, and there's also not good blood flow. You require good blood flow for an erection, and they don't have it. Okay. Ulcers on the feet or the toes. That is from PAD. That is also from diabetic neuropathy. They don't feel anything down there, right? They can't feel extremes of hot or cold. They don't know oftentimes when they have an injury. All right, how do we diagnose? This will be on your test. So we're going to do it in order. If I have a patient that comes in and is like, man, my vision's been blurred and I just feel really crappy, and the patient's BMI is 28, right? And they're very overweight and they have hyperlipidemia, then I'm just like, this is a red flag, right? So now they just came into the office, right? So I would just do, okay, I can test a blood glucose right now, but you haven't been fasting. I don't know what you ate before you came here, right? So a random blood glucose would have to be over 200 with signs and symptoms of diabetes, okay? But I'm not going to diagnose that off of that, obviously, but that would clue me in like, this ain't good, right? Because even after you eat, your sugar should not go up to 200, right? Your sugar may go up to like 140 before your insulin really kicks in, okay? So then I'm going to tell the patient, hey, I need you to come back tomorrow fasting so I can see what your fasting blood glucose is. So a fasting plasma glucose or fasting blood glucose over 126 on at least 2 occasions. Because diagnosing somebody with type 2 diabetes is not a joke, right? There's a lot that goes along with this. So I want to be sure before I diagnose, because sometimes patients lie and they will say they're fasting, but they got hungry on the way. Okay. And so they may have eaten something, but they don't tell you that, right? And then what happens if I give this patient oral hypoglycemic medicine when they don't really have diabetes? You're going to cause massive hypoglycemia and you could kill someone. So, has to be on at least 2 occasions, okay? Plus a hemoglobin A1C of greater than 6.5%. What is a hemoglobin A1C? How does it test for 3 months of your blood sugar? Well, you're going to learn today. What's hemoglobin? All right, so it's there are 4 chairs on every red blood cell, right? And that's what carries oxygen. Yes? Okay. But the hemoglobin also picks up other little junky things along the way. Sugar likes to sit in the seat too. How long is a red blood cell's life? 120 days. I wonder how many months that is. That's 3 months. So it looks at the lifespan of the red blood cells and how much sugar clung to the hemoglobin on that red blood cell for its 3-month lifespan. Damn, okay, now we understand. Shoot. Okay, so that's a hemoglobin A1C. So if it's more than 6.5%, which basically means more than 6.5% of those hemoglobin seats were occupied with sugar instead of oxygen, then you probably got the diabetes, because that means a lot of sugar was just running around in your blood to get stuck on those chairs. You with? Yeah. All right. So number 1 treatment for type 2 diabetes, what do we tell them to do first? Lifestyle modifications. Number 2, oral hypoglycemics, which is oral drugs. If those don't work, or what do we move to next? Insulin. Can we go backwards? Yes, if your patient can get on the bandwagon of getting healthy. Okay. All right. When we are teaching, turn this over because I've taught you all of this. When we are teaching a patient, what's the first thing you would teach a patient newly diagnosed with type 2 diabetes? What do you think? I would teach them how to take a blood glucose first, right? That's something very simple, and they're going to need to do that pretty much every single day. They need to take it before meals, after meals, before bed, and first thing waking in the morning, right? So I would teach them that. What else do you need to teach them? How to count their carbs, how to read nutrition labels, right? How to find where the carbs are. And then they have to be able to calculate, if they're on insulin, which they may be, they have to calculate their insulin dose based off the carbs that they had. What else do you want to teach them? You've learned a lot today, huh? Signs and symptoms of what? Hyperglycemia or hypo? You tell me. Okay, so I would teach hypoglycemia. Hold on one second.